You'll probably think of aneurysms, those bulges happening in arteries,
Yeah.
right, the high-pressure pipes. But get this, they can actually show up in veins, too. The lower pressure return lines, often totally silent, sometimes.
That's exactly right. Welcome to the deep dive. Today we're looking into something maybe less familiar, venous aneurysms. We've been digging into Rutherford's vascular surgery and endovascular therapy, the big textbook, to really understand these unusual vein dilations,
Okay.
how they're different from the arterial ones everyone knows, and, why it actually matters.
All right, let's unpack this then. Veins. They're generally thinner, lower pressure. A bulge there almost sounds, well, wrong.
Yeah.
So our mission for you today is to pull out the essential info. What are they exactly? What causes them? Where do they show up? What
Good.
trouble can they cause? And importantly, how are they managed? Consider this your fast track to knowing about a rare but potentially significant vascular issue.
Okay, let's start with the definition. Gillespie and his colleagues laid it out pretty clearly. It's a solitary localized dilation, communicates with the normal vein through just one channel. And crucially, it's not from an artery-vein connection, an AV communication. Not a pseudoaneurysm either, which is more like a contained leak. And definitely not just lumpy varicose veins.
So very specific, not your average bumpy vein.
Yeah.
And size-wise, how big are we talking before it's called an aneurysm?
Yeah, the general rule of thumb is about 2 to 3 times the diameter of the normal vein right next to it.
Okay.
But, since they're often asymptomatic, we don't really have a solid grip on how common they truly are. They often just fly under the radar.
Makes sense. No symptoms, no reason to look, right?
Yeah.
So what causes a vein to balloon out like that? Is it something you're born with, or does it develop?
It can be either, actually. We talk about primary, which are congenital, basically. They're from birth. And then secondary, which are acquired later on. The primary ones are sometimes linked to inherited conditions. Things that affect vessel walls, like Klippel-Trenaunay syndrome or neurofibromatosis type 1, NF1, even Parkes-Weber syndrome. Chapter 171 in Rutherford's goes into more detail on those congenital vascular issues, if you're interested.
So genetics can play a role. What about the secondary ones? What triggers those later in life?
Well, there's a few things. Trauma to the vein is one. Inflammation, just sort of degenerative changes over time can weaken the vein wall.
Right.
Mechanical stress, maybe from repeated activity, or even chronic venous hypertension that's persistently high pressure in the veins. And interestingly, there's been some talk about a connection with pregnancy.
Pregnancy? Really? That seems unexpected. How so?
Well, it's not definitively proved, cause and effect, but we do know veins have estrogen receptors.
Oh.
So the thinking is maybe the hormonal shifts during pregnancy could affect the vein wall structure, make it a bit more prone to dilating. But yeah, still an area being looked into.
Fascinating stuff. So whether it's from birth or develops later, the vein wall itself is key. What do they look like under the microscope? Any specific changes?
Histologically, yeah, you often see changes. That inner lining might be thickened and fibrotic. But more strikingly, the middle muscle layer can be thinned out, maybe even absent in spots. Fewer smooth muscle cells or none at all.
Okay, less muscle.
Exactly. And what's really interesting, kind of linking back to arterial aneurysms, is finding higher levels of matrix metalloproteinases, MMPs.
MMPs, right, I remember those. They break down tissue in artery aneurysms.
Precisely. They chew up the structural proteins in the artery wall, contributing to weakness and dilation. Finding them elevated in venous aneurysms, too, suggests, well, maybe a similar process is happening, but the evidence isn't quite as solid for veins as it is for arteries. We need more research to really nail down the role of MMPs here.
Okay, so we've got a handle on what they are, how they might form, but how do people find out they have one? Do they cause obvious problems?
Most of the time, actually, no. They're asymptomatic, which, again, is why we probably underestimate how many people have them.
Right.
But when complications do happen, they can include thrombosis clots forming inside the aneurysm,
Okay.
embolization, those clots breaking loose and traveling, potentially causing a pulmonary embolism, a PE.
That's serious.
Very. Rupture can happen, but it's rare for veins. Also, local mass effects, pressing on things nearby, causing swelling or edema. And sometimes just localized pain or tenderness right over the aneurysm.
So silent but potentially risky down the road. How are they usually found then?
Yeah.
Diagnosed?
Well, if it's superficial, near the skin, you might feel it on a physical exam, a lump. But they can get mistaken for other things, soft tissue masses, cysts, even hernias sometimes.
Hmm.
For deeper ones or to confirm a superficial one, imaging is really key. Duplex ultrasound is usually the first stop. CT scans, MRI, they can also give great pictures, show the size, extent, all that. Venography, injecting dye for x-rays, that's generally not the main tool for diagnosis here.
Got it. Imaging is crucial. What about the patient's history? Does that help?
Oh, absolutely. You need a thorough history. Any family history of aneurysms, connective tissue disorders, that might point towards a primary congenital type.
Right.
Any past trauma to the area could explain a secondary one. And like we mentioned, a physical exam should check for signs of an AV fistula, just in case that's playing a role. Might need imaging to look into that too.
Okay, so let's say one is found. What's the game plan? How do you manage it?
It's very case by case, honestly. There aren't huge studies giving us definitive rules. For small ones, asymptomatic ones, conservative management is often the way. Just watching it, regular follow-up imaging.
Okay, watchful waiting.
Exactly. But for larger ones, or any that are causing symptoms or complications, then surgery usually comes into play.
And what kind of surgical options are there?
Several techniques. You could do what's called a tangential aneurysmectomy, just take out the bulge and repair the vein wall. That's often preferred if possible. Or you might need to resect the whole segment and sew the ends back together. That's primary anastomosis. If there's a gap, you might use a piece of another vein, like the saphenous or sometimes even a synthetic graft, to bridge it. That's interposition grafting. And sometimes just simple ligation, tying off the vein segment, is an option. Interestingly, while we don't have standard endovascular treatments like for arteries, things like stents, they have been used successfully in some specific cases.
So a few tools in the toolbox, tailored to the situation. Let's zone in on locations now. You said they can be anywhere. Lower legs seem common. What about superficial leg veins?
Yeah, superficial ones in the legs often show up as these visible, painless lumps. Like you said, easily mistaken for other things, cysts, maybe a hernia in the groin.
Right.
A good exam trick is checking compression. They might feel firmer, less easy to squish when the leg's hanging down versus elevated. Duplex ultrasound confirms it. Sometimes they're even found by surprise during varicose vein surgery. And there are these pedal venous aneurysms on the foot. Weirdly, almost all reported cases are in young women.
Young women specifically. Any idea why? That's odd.
It is odd. The why isn't clear. Maybe something about repetitive minor trauma, footwear, activity levels in that group. It's mostly speculation, though.
Interesting. So how do you treat these superficial ones in the leg?
Usually ligation, tying it off, and excision, removing it, provided the deep system is okay, of course. If it's near the saphenofemoral junction, the groin crease where the main superficial vein joins the deep vein, you'd often do a high ligation too.
Okay.
There's also been some use of endovenous thermal ablation, the heat treatment for varicose veins, for saphenous veins that have aneurysms near the junctions, maybe combined with high ligation for larger ones. And rarely you can get aneurysms in perforating veins, the ones connecting superficial and deep. If they're big, like over 9 millimeters on ultrasound and causing issues, they might be treated like reflexing veins, maybe ligation.
Okay, let's go deeper. The deep veins. Popliteal vein, behind the knee. You said that was the most common.
That's right. Popliteal venous aneurysms are the ones we see reported most often, the ones we probably understand best. And they seem to have a stronger link to complications than the superficial ones.
Like what kind of complications?
Thrombosis, definitely. Pulmonary embolisms, a big one. In fact, a lot of these popliteal aneurysms, maybe 45% to even 80% in some studies, are found because the patient had a PE and they were looking for the source.
Wow. So the PE happens first, then they find the aneurysm.
Often, yes. Or they might cause local pain, swelling, sometimes diffuse leg swelling, or even symptoms of chronic venous insufficiency. There was a treatment algorithm proposed by Narpany and colleagues based on size, particularly over 20 millimeters, and whether there was turbulent blood flow inside seen on ultrasound.
Turbulent flow, so how the blood is swirling around in there matters.
It seems to. They found aneurysms over 20 millimeters often had this turbulent flow and were more likely treated surgically. Though, interestingly, some large ones without turbulent flow seemed stable just being watched. For smaller ones, under 20 millimeter, that turbulent flow seemed to be a key factor pushing towards surgery.
So not just size, but flow dynamics too. What's an overall strategy then for these popliteal ones?
Well, if it's small, under 20 millimeter, no symptoms, no turbulent flow, watching it with regular ultrasounds is often reasonable. Check for growth, check for clots.
Makes sense.
But if the patient is symptomatic, especially if they've already had a PE, then treatment is generally recommended, pretty much regardless of size.
And just blood thinners aren't enough.
Generally not considered sufficient on their own. Clots can still form in the aneurysm sac even on anticoagulation, and they can still embolize.
Oh, okay.
So surgery is often the way. Tangential aneurysmectomy with that lateral repair of anorrhaphy is often preferred. Resection with sewing ends together or using a graft saphenous vein, maybe spiraled, or even synthetic. Those synthetic grafts have a higher clot risk.
Right.
Sometimes an IVC filter might be placed temporarily or thrombolysis to dissolve existing clot, but that's case by case. Post-op anticoagulation for 3 to 6 months is pretty common after repair.
And you mentioned another technique, a closed alexcation.
Yes, Bewley described that. It's like folding or tucking the aneurysm wall inward with sutures reinforced with little pledgets. They reported good results and notably didn't routinely use anticoagulation afterwards with this method. It can sometimes avoid needing big dissections or prosthetic material if there's already clot inside.
Interesting alternative. What about other deep leg veins, femoral, iliac, up near the pelvis?
Femoral and common femoral aneurysms are much rarer than popliteal. Not much specific data because they're so uncommon.
So you extrapolate.
Pretty much. Based on the popliteal experience, symptomatic ones probably need surgery. Small asymptomatic ones you'd likely monitor for size changes or clot. Iliac vein aneurysms are also rare. Rupture has been reported in a few large external iliac ones, but mostly they're asymptomatic, found incidentally or during a PE workup.
Any patterns with the iliac ones?
Yes, a review by Zarantan found they tend to be more common on the left side and more often in the external iliac vein, and some potential gender differences in presentation. Men more often had limb swelling or pain, maybe history of trauma. Women were more often asymptomatic, but had a higher link to May-Thurner syndrome.
May-Thurner, remind me.
That's where the right iliac artery compresses the left iliac vein, can cause DVT, or apparently sometimes associated with these aneurysms.
Got it. And treatment for iliacs, similar approach.
Generally, yes. Tangential aneurysmectomy and repair is preferred. You really want to avoid ligating the iliac vein if possible. High risk of long-term leg swelling, post-thrombotic syndrome.
Makes sense.
If it's linked to an AV fistula, the thinking is often to fix the artery side first, maybe with a covered stent, then resect the venous aneurysm.
Okay, covered the legs pretty well. Let's move up. Abdomen. Inferior vena cava aneurysm, the IVC. That's major.
It is potentially serious, yes. The normal IVC is maybe, 1.5 to 3.7 centimeters across? It's considered aneurysmal if it gets over 5 centimeters. Very real, though. Fewer than 60 cases reported, often asymptomatic, found on imaging for something else. Sometimes the first sign is actually thrombosis in the iliac veins in IVC. There's a classification system by Gradman and Steinberg for these.
How does that work? Does it guide treatment?
It divides them into 4 types based on location relative to the liver and kidneys and whether there's obstruction. Type 1 is above the liver, no obstruction, often just observed. But types 2, 3, and 4, which are either obstructed or below the kidneys, are thought to be a higher risk for clots or emboli. So they're usually treated.
Surgically.
Yes, usually surgical repair, either excision and repair or resection and bypass grafting. The idea is those obstructed or lower ones might have slower flow, more prone to clotting.
Right. What about the other abdominal veins? Visceral veins, portal, mesenteric, splenic, renal. That sounds really obscure.
Extremely rare, you're right. Portal vein aneurysms are actually the most common of the visceral venous ones reported, relatively speaking.
Yeah.
Over 15 millimeter diameter, or maybe over 19 millimeter if you have cirrhosis, is considered aneurysmal there.
And symptoms.
Often nonspecific abdominal pain, maybe half the time. About a third are asymptomatic, found incidentally, maybe 20% present with thrombosis, a clot inside. Rupture is very rare. Causes can be congenital, related to embryonic development, or acquired things like portal hypertension, trauma, pancreatitis, even malignancy nearby.
And you manage those portal vein aneurysms.
Generally, treatment's advised if they're over 3 centimeters, or smaller ones that cause problems, rupture, clots, pain, growing fast. If the patient's fit for surgery, if there's no portal hypertension, you might do a tangential aneurysectomy and repair, but bleeding risk is a concern. If there is portal hypertension, you really need to address that underlying issue, maybe shunting procedures or even liver transplant in some cases. And interestingly, some have been reported to just shrink on their own spontaneous regression.
And the others? Mesenteric, splenic, renal quickly.
Mesenteric. Super rare, abdominal pain, most common symptom. Mostly watched, but surgery recommended if symptomatic or over 3 centimeters symptomatic due to a report of rupture. Splenic vein, less common than splenic artery aneurysms. sometimes happen after an artery aneurysm ruptures into the vein. Treat if symptomatic, women of childbearing age, or over 2.5 centimeter renal vein. Also rare, abdominal pain or asymptomatic. Surgical repair, maybe even removing the kidney in some cases, if symptomatic. Need to differentiate from just dilated veins due to things like nutcracker syndrome or shunts.
Wow, okay, a tour through the abdominal rarities. Let's finish up with the upper body. Arms, neck, head. Are they common there?
Less common than the legs, we think, but they definitely occur. Superficial arm ones can cause pain or swelling or be asymptomatic lumps often mistaken for other masses until surgery. Good physical exam helps checking compression, Valsalva maneuver. Duplex ultrasound nails the diagnosis. Treatment is usually for symptoms or cosmetic reasons, surgical excision after mapping the feeding vessels with ultrasound. We're not really talking about the pseudoaneurysms you see with dialysis fistulas here. That's separate.
That's good. And deeper veins in the arm. Brachial, axillary, subclavian.
Those are usually asymptomatic too. A painless, slow-growing mass might be the only sign. Valsalva might make it pop out more if visible. Ultrasound diagnoses it, maybe CT or MRI for planning if needed. Literature's limited, but PE has been reported, though rarely. Generally considered lower risk than popliteal. Local discomfort can happen.
So treatment.
Recommendation is usually aneurysmectomy and reconstruction if they're symptomatic. Asymptomatic ones. Could observe, could treat surgically, depending on the patient.
Okay, last stop. The neck. Jugular vein aneurysms. Those must be noticeable.
Often they are, as a lump, but usually painless and asymptomatic otherwise. Frequently misdiagnosed initially as other neck masses. We see congenital cases in kids sometimes. Can happen in adults, less common. There's an association noted with NF1 again.
And treatment. Mainly cosmetic.
Primarily, yeah. Pulmonary embolism risk is thought to be very low, so surgical resection, maybe ligation of feeding vessels if the other side drains okay. Spontaneous shrinking has even been reported in kids. You might see it bulge dramatically with Valsalva, but usually a benign course.
Quite the journey through the venous system. Okay, to wrap up this deep dive, what are the absolute key takeaways for us on venous aneurysms?
I'd say the main things are they're rare, can happen pretty much anywhere in the venous system, often found by accident, during imaging or a PE workup. Many are asymptomatic, but complications can be serious, especially depending on location, like the popliteal vein. Treatment is very individualized. Surgery for larger or symptomatic ones, observation often for small asymptomatic ones, and that tangential aneurysmectomy with lateral venorrhea, that repair technique, is often the go-to surgical method when needed. But yeah, definitely need more research for clearer guidelines.
So even in vascular surgery, there are these less charted territories. It really makes you think, with imaging getting so much better and being used so much more, are we just going to start finding these venous aneurysms more often now? And if we do, how is that going to change how we understand them, their natural history, and how best to manage them? Definitely food for thought. Thanks for taking us through all that really fascinating stuff.